أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم ثم خلقنا النطفة فخلقنا العلقة مضغة فخلقنا المضغة عظاما فكسونا العظام لحما ثم أنشأناه خلقا آخر فتبارك الله أحسن الخالقين। शुरू अल्लाह के नाम से जो नहायत मेहरबान रहम वाला है। फिर हमने उस बूंद को जमे हुए खून की शक्ल दे दी, फिर इस जमे हुए खून को एक लोथड़ा बना दिया, फिर इस लोथड़े को हड्डियों में तब्दील कर दिया, फिर इस जमे हुए खून को एक लोथड़ा बना दिया, फिर इस लोथड़े को हड्डियों में तब्दील कर दिया, फिर हड्डियों को गोश्त का लिबास पहनाया, फिर उसे ऐसी उठान दी कि वो एक दूसरी ही मखलूक बनकर खड़ा हो गया। गर्ज बड़ी शान है अल्लाह की जो सारे कारीगरों से बढ़कर कारीगर है। सदक़ल्लाहुल अज़ीम।
Subhanallah. I welcome all of you on behalf of this webinar. ये हमारा 154th वेबिनार है और इट इज़ विद द कोलैबोरेशन ऑफ वुमेन मेडिकल कॉलेज अहमदाबाद एंड साउथ एशियन एसोसिएशन ऑफ फिजियोलॉजिस्ट, पाकिस्तान फिजियोलॉजी सोसाइटी, पाकिस्तान एसोसिएशन ऑफ पैथोलॉजिस्ट and Medical Women Association of the Pakistan. I will request Professor Salma Kundi to introduce Syed Qasim Shah Saab, who is the consultant orthopedic surgeon of Jinnah International Hospital in Ahmedabad. Professor Salma.
Thank you so much, Dr. Mulazim Hussain Bukhari साहब. डॉक्टर सैयद कासिम शाह साहब जी हमारे प्रोफेसर साहब हैं ऑफ ऑर्थोपेडिक. ही वर्क्स एट जिना इंटरनेशनल हॉस्पिटल एबटाबाद, which is our college, our affiliated hospital of Women Medical College, our own hospital. And he is a fantastic surgeon, and what he's going to touch today is the hip fracture. और नेक्स्ट टाइम इनसे फिर हम इस्तदा करेंगे कि हमें नीज के ऊपर और ऑस्टियोआर्थराइटिस के ऊपर भी कुछ बता दें. तो ओवर टू यू कासिम शाह साहब. थैंक यू.
थैंक यू जी. बिस्मिल्लाहिर्रहमानिर्रहीम. रब्बि इश्रह ली सदरी वयस्सिर ली अमरी वहलुल उक़दतम मिन लिसानी यफ़क़हू क़ौली. तो एक तो पहले बड़ी मैं माज़रत चाहूँगा आपको कि अब संडे के दिन ऐसा आपको सुनना पड़ रहा है. मेरी आवाज़ आ रही है आपको?
जी, वेरी क्लियर.
ठीक है जी. मुझे वो मुश्ताक यूसुफ़ी साहब का वो याद आता है, कहीं लाइन पड़ी थी कि वो बहुत सारी उन्होंने बुरी चीज़ें जो बताई थी. तो एक्सक्यूज में मेरा गला भी ज़रा थोड़ा सा आज खराब है. तो एक उन्होंने ये बताया था कि जी इतवार का मुलाकाती है. तो इतवार का मुलाकाती तो शायद बुरा हो, और ऊपर से फिर आपको ये सेमिनार भी सुनना पड़ रहा है. एनी हाउ, ये टॉपिक इसलिए सिलेक्ट किया था कि ये आए रोज़ हमारे यहाँ हमारी फैमिलीज़ में ये बहुत बड़ा एक मसला है और लोगों को अभी तक इसकी प्रॉपर समझ नहीं है. बिकॉज
excuse me
जी आवाज़ आ
Dr.
रही है?
Qasim, can
जी
you
जी
please switch to English because
हाँ
Angelic
हाँ
is here, she doesn't
या
understand Urdu.
Yeah, we selected this topic because it's a very common day, and every now and then we come across patients within our families, within our, I mean, near dear ones who suffer these fractures. These are also known as the fragility fractures because it usually occurs in elderly patients, and unfortunately, women are the, I mean, 75% of the patients are women. And if you can see the slide, this epidemiology and public health burden, this 1.6 million burden per year globally. And although I think it's a bit higher than this figure because as it is reported now in 2020, but I read the same figure in 1990 as well. So probably it is, I think 2.6 million would be, I mean, near to that figure. So, and secondly, the cost of treating these fractures is very high. And unfortunately, we do not have, particularly in hospitals and in setups within the third world countries, we do not have much hospitals and much trained surgeons and much perioperative care centers where these patients can be properly treated. So as you see that the projected this burden would be by the 2050 would be 6.3 million, which I think it would be more than this. And as the life expectancy is increasing, particularly in our region as well, so it's this burden is increasing by every day. As I told you that the higher incidence is found in females because the osteoporosis is a main concern, and post-menopausal women usually suffer more than these, although nutritional and other factors do affect, but this post-menopausal status usually it's a big challenge as well. And the mortality is very high. Previously, we used to talk about that the mortality of these fractures is almost 30%. You see that the 30 days mortality we used to tell to the patients, and we would try to counsel the patients that with or without operation, usually 30% of the patients used to perish away. But of those 70% who had few days of life left, their quality of life much improved with the fixation of the fractures. And not only for the patients, but for the family as well. Because this fracture, if it occurs in a family, and in a near dear one, usually a grandmother, maybe maternal or the maternal. So it's not just the patient, because whole family suffers from this fracture, because you cannot take care of such patients just by one person. You always need 2, 3 persons to take care of that, and still that, it's terrible. I remember many patients in my life. It has been long time, for the 20, 30 years that I've been operating upon these patients, that many patients who can afford, who usually they are, well-off patients, but they're usually denied of patients. I still remember a person who came to this clinic with a fractured neck of femur, and he was an officer, and his sons were in a very well good positions. But somehow they refused the operation. And then I remember that after a year or so, a person came to a patient brought to my clinic, and this was so foul smelling that of the urine was coming out from all his clothes and all the bedding. And that was the same person. So he actually survived that initial 30%, death risk. But the quality of life was so poor that all his bedding was wet with the urine, and he was drenched in urine. So if he was properly convinced, and he was treated by this either fixation or orthoplasty, he would have much a better life expectancy. So epidemiology, you see, it's a great burden globally. Although it is geographically, it was said that the Scandinavian and US and Western nations suffer more, but in our region, it is not less common. Only in the past 2 days, I operated upon patients, one male and one female. Both were above 90 years. So, the next thing is that there is a very minor trauma here. The risk factors, you see, age incidence doubles every decade after 50, which means that if you have got a 1% chance of developing this fracture in 50, so in 60s, it may become 2%, and so on. It increases, and the highest risk is in 80s, and in your 90s, definitely it's much higher. Secondly, it is said that no big falls are required for this fracture to occur. It usually occurs at night time when the patient tries to go to bathroom usually. And it's a very common history in all these kind of patients. So as we'll discuss further in the next sessions, how to prevent these fractures. So one of the mechanism is that we should have a good ambulatory conditions and provisions in and around that patient. Particularly, there should be a good light in the room. There should be no abnormal, the carpets or other hurdles in between the way to the bathrooms. And secondly, if the patient requires support for walking, he or she must be provided promptly by the family. And in certain cases, there is actually no clear history of fall. we call it occult fractures. These patients, they are ambulatory, they come with the groin pain. And only after detailed investigations, usually we have to do MRI to find out that there is the fracture. And the pain and all things can be improved by fixation in that conditions. So vitamin D deficiency and calcium deficiencies, these are definitely there. Some patients may have other medicines like steroids, anticoagulants, or anti-epileptics, such things. They can also add to the seriousness of these patients, and they can even cause these patients. Similarly, comorbidities, particularly dementia patients, usually if they are not well care of, so usually their eating habits are such that they may not take proper medicines, proper food, and what about to talk about the exercise and other things. So now if we talk specifically about the anatomy of the femur and of the proximal femur here, hip joint is usually formed by a head of the femur which articulates with acetabulum, and it's a quite a deep structure. It's a ball and socket type of joint which nature has provided a good strength usually. But there is a neck which attaches the head of the femur to the shaft of the femur, and it makes an angle. It is here which is the fractures most commonly occurs. We will classify it in the next section. But the main structures, femoral head, greater trach, intertrach region, and the neck of the region, that is very important because the attachment of the capsule of the hip joint, it comes further and it attaches anteriorly to the intertrochanteric line, and posteriorly it is slightly shortened. So what is more important is that the blood supply here is slightly precarious because the most of the blood supply, as it is shown in the next session here, it is the lateral and medial circumflex arteries, which are the branches of the profunda femoris. And these come and they form a retinacular network which provides to the head of the femur. This blood supply is very important because it is in the first place, it's meager, it's not very, too much of the blood supply. And whenever a fracture occurs, that definitely this blood supply usually suffer, and there's a great chance of AVN, avascular necrosis of the head of the femur. So it's very important that if a fracture occurs in this region, and if it's a patient is a young one, which usually due to, high-speed injuries, for example, road traffic accidents or fall from heights. Otherwise, in these elderly patients, this is not usually a problem. Then we'll discuss in detail in the classification and the treatment section. But in young patients, it is very important that if a patient suffers from cervical fracture of the femur, which means that the neck of the femur, we also call it intracapsular fracture neck of the femur, it should be treated promptly as early as possible. The best results are considered to be done if the operation is done in the first 24 hours. However, if, as I told you earlier, that in many centers, and we do not have too many centers in the city, usually we have, because it requires an orthopedic table, a trained orthopedic surgeon, and an image intensifier. And these usually are not available in every hospital. So in many cases, these patients, they suffer delay, and the result is that there are more chances of avascular necrosis of the head of the femur. So the blood supply is important for the head of the femur as well. Then there are some fractures which occur outside this neck. We call them trochanteric fractures, or post-trochanteric fractures, or extracapsular fractures, neck of the femur. Here, the structures lie the greater trach and the lesser trach. And the blood supply here is, quite good because we have a lot of retinaculum and the multiple anastomosis are there. So blood supply is not a problem here, and the quality of bone is also good, calcareous bone, which usually heals quite well. So the fracture of the trochanteric regions, but usually these fractures occur in later decades of life. Even the cervical fractures a decade later than the fractures which occur in the cervical lesion. So the problem again is that healing is not a problem, but lying in bed is a problem, because these patients, they usually have many comorbidities, and if they lie in the bed for few months, few weeks, the fracture would definitely heal, but the patient would hardly survive, and she would develop the bed sores, DVT, pulmonary embolism, pneumonia, and chest compression, and so on. You name the complication, and these patients develop very easily. So that's why again, in these fractures, the main concern is that we should fix these fractures as early as possible. And it is said that again, in these fractures, even although the blood supply is good and non AVN is not a problem, but delaying the treatment is again detrimental for the good outcome, because delay with more than 48 hours, it would grossly affect the outcome of the patient, and these complications, deadly complications, would, I mean, really badly affect the patient. As I already mentioned, that we have two types of fractures: intracapsular. We further classify them subcapital fractures just below the head of the femur, and transcervical, the main portion of the neck of the femur, and basicervical, where the neck of the femur attaches with the shaft of the femur. So these three types, they have some, I mean, treatment effect and some outcome effect also. The extracapsular fractures, as I told you, that it is the intertrochanteric region or the subtrochanteric region, which is subtrochanteric is the area which is 5 centimeter below the lesser troch. We classify this separately because we do not treat it as a shaft fracture, because here the mechanical forces are such that usually the proximal segment is abducted here. So we need a strong fixation which not only maintain that, which counter the abductive forces and maintain the, I mean, reduction till the fracture heal. And again, these subtrochanteric fractures, they are common both in elderly patients as well as in the younger patients with the high-speed trauma. As you see here in the red lines below at the bottom, that the blood supply to the intracapsular fracture, the main concern is AVN and non-union. AVN means avascular necrosis of the head of the femur. And this AVN occurs slowly. It is not immediately, it is not, I mean, evident. And that's why, and usually we fix these fractures only in younger patients. We'll describe this in the treatment section or in the classification section as well. But the two main problems are the AVN and non-union. The extracapsular fractures, blood supply is good, AVN is rare, healing is also good. The problem is that these patients staying in bed is more dangerous. So we need to fix these fractures as early as possible, even considering all the comorbidities. But to the main aim of the treatment is that to make these patients ambulatory as early as possible, or to make them sit in the bed and to avoid the bed sores and all other chest complications which occurs due to lying in bed. And the next is the classification. There are many classifications which are used for these fractures, but the most common is this Garden classification. There is another Paul classification, and there is another AO classification as well. But this is practically a simple and commonly used Garden. It has got 4 subtypes. Type 1 is an incomplete fracture. Type 2 is a complete but impacted fracture. Type 3 is partially displaced fracture, and type 4 is a completely displaced fracture. As you see here that in type 1, this is the AVN risk is slightly low. But overall, that we use these classifications, my practical experience, it shows that basically it is the age of the patient that is more important in deciding which treatment option is best for which age group. For example, if the patient is usually we see that the physical age as well as the physiological age of the patient in deciding what treatment should suit a particular patient. Generally, it is recommended in the books that a patient over 65, they should have arthroplasties instead of fixation, because they are, and their uniting union of these fractures is, I mean, time consuming and usually results in non-union and again the delayed physiotherapy and all these complications. But once if you treat them with arthroplasties, either partial or total hip arthroplasties, it would become much easier for these patients to be rehabilitated in their proper lifestyle. Anyhow, if the patient is young, then we will try to save the head of the femur and we'll try to fix in almost all these types. But the problem is that even if you, I mean, fix these fractures, for example, grade 3 and grade 4, the risk of AVN is much higher, usually high in 30 to 35%, even in partially displaced fractures, not to name the fully displaced fractures. But still, the best option is that for patients younger than 60 years of age, it is better to go for, I mean, close reduction and fixation of these fractures. However, nowadays there's a trend also that even if the patient is of 52 and above, and if she can afford or the facilities are there, the best thing is to go for total hip arthroplasties, because that is a more stable arthroplasty, and patient can be ambulatory and can do an uh, active lifestyle. Can have an active lifestyle. This is the diagrammatic representation of this Gardner classification. Type 1 is, this is the type 1 and type 2 are partial, undisplaced fractures usually. Type 1 is incomplete, type 2 is complete but impacted, type 3 is partially displaced, and type 4 is a completely displaced fractures. These are other AO, not TA classifications, same. There is another even Jensen classification for intertrochanteric classifications. These are just for the academic purposes. Otherwise, we try to, I mean, fix all these fractures. And these fractures are labeled as usually minimally displaced and two-part fractures to the extreme extent, comminuted fractures and reverse oblique fractures. These are the axes of the, for example, the first is the subcapital fracture. The fracture is just below the head of the femur. And this transcervical just in the middle of the neck of the femur fracture. And this third fracture is the basicervical fracture, where the neck of the femur is attaches to the shaft, the intertrochanteric line. Again, some X-rays are shown with these fractures. Sometimes it becomes difficult to diagnose these fractures on initial X-rays. So either we repeat or we just do the MRI and sometimes CT scan that will help to occult fractures or fractures which are not very clear initially, or where there is no clear history of trauma. Classic presentation, clinical presentation of these patients, elderly patients following a low energy fall. As I told you, that most of the time it is during the night that the patient really tries to get up and attend the bathroom, and in the way just he or she falls and get this fracture. And after that, he or she cannot wait beer. That is a very important sign that the patient cannot stand again. But sometimes in impacted fractures or a relatively younger patient may present with a chronic groin pain, or sometimes the pain is referred to the knee from them. The third common presentation symptom is the inability to bear weight. And typically, if a patient is brought in a bed, the there is typically a shortened, externally rotated limb. Groin tenderness or palpation and pain on axial loading of the limb. These are the signs which we can elicit on clinical examination. Atypical and occult presentations. Ambulatory patients with groin ache. Pediatric patients, high energy trauma, fall from height, stress fractures in athletes, military recruits, pathological fractures, metastasis, pagestheses. And mind you, that is usually the subtrochanteric fractures, because that is the region which is more prone to these metastases, particularly from the breast, lungs, and the prostate, etc. And sometimes the only sign is the presentation to the knee with no hip pain. Actually, the patient presents with a knee pain, and only after a clinical examination and investigations, we see that there is a problem is in the hip and there is a fracture. We just had a patient, a few weeks back, I operated upon a patient who presented to me with a groin pain, and he was hardly 63, 64 years of worker who used to work on a tandoor, and he used to make breads. And he was just having a pain, and we tried to treat, and there was no access signs in the X-rays initially on the hip. So we treated him for the groin pain and the thigh pain, but that was in vain. So ultimately, he did an MRI, and a occult fracture was found there. And then we did the orthoplasty for him and partial hip replacement. A bipolar implant was inserted, and he is improving now. Investigations, X-rays, AP pelvis, and lateral view. Usually, it is the X-rays in the AP view that in the most, almost in 90-80% of the patients, it can very easily tell about the fracture. In certain cases, we need to have an MRI, which not only can tell about the bones, but other associated conditions of the vessel and soft tissues, etc. Still, sometimes a CT scan is required, the bone scan and other, but bloods and ECG, these are required for other. If the patient is going to be get operated, then we need a complete workup, not only for the blood and ECG, sometimes echo is required, and other the full blood count and the bleeding profile and urea creatinine, etc., etc. Now the treatment principles. We have mentioned here the conservative treatment, that non-ambulatory patients, severe comorbidities, non-displaced stress fractures, and patient family refusal of surgery. That refusal of surgery is the one main point. Otherwise, I don't think that there is a conservative treatment for hip fractures. Because even if I have seen that the patients who presented with incomplete fractures, after a week of 10 days of rest in the bed, when the X-rays were done again, there was a complete and a displaced fractures. So if the patient condition allows, the best thing is the surgical fixation. Otherwise, this method of skin traction for pain relief, or sometimes they, and when we were in training, we used to apply hip spica for these, patients. And now I think that that was a more terrible, than the original condition. That hip spica was a very terrible type of treatment, but we did a lot in our early days. Anyhow, so conservative treatment, hardly successful, only for can be used for a little bit of pain relief. Otherwise, outcome is very, bleak. So for this dynamic hip screw, it is a gold standard treatment still for the intertrochanteric and the extracapsular fractures of neck of femur. It consists of a central screw which we put in the center of the neck of the femur, and then it is attached to a side plate. But all this requires again an operative setup, which requires an orthopedic table, a trained orthopedic surgeon, and an image intensifier, good image intensifier, and a trained team to have a good results. So the advantage of this fixation is that the patient is pain-free on the very next morning, And if the fracture is a stable one and you have done a good fixation, you can make him or her weight bear on the very next day. And the patient's pain is improved and the physiotherapy can be started. He can sit in the bed and he can, the hope of the good outcomes are much improved. So the technique, as I told you, lax screw in femoral head plus sliding barrel plate on lateral cortex allows controlled impaction. And when the patient starts weight bearing, the fracture segments, they are impacted and they are compressed into each other, which helps in the healing process. So excellent for stable patterns. However, in unstable patients, we try to avoid this early ambulation or early weight bearing, but still the pain is much improved. Then there is another treatment for usually reverse oblique fractures of these, again, this trochanteric region or subtrochanteric region, that is called intramedullary nailing or proximal femoral nail, PFN we call them. Their advantage, they are more difficult to insert and they are more costly, and many studies have failed to confirm added advantage over this DHS. But subtrochanteric fractures, that is a good indication for these intramedullary nails. This first axis, this shows the proximal PFN, proximal femoral nail, and again here it is almost a subtrochanteric type of fracture. The second axis, although not a very good X-ray, but it shows the cannulated screws fixation of the almost basicervical type of fracture. And this shows a total hip replacement, and it is cementless. Usually we use in younger patients this type of fixation, the orthoplasty, because here the quality of the bone is good and the screws can hold the stabular part in position. They are more, reliable, and it is usually for those patients who are more ambulant and they are more active in the life. Perioperative management is very important actually, because usually, as I told you earlier, that these are the fragility fractures mostly occurring in the elderly patients. So if usually they present with comorbidities, particularly cardiac missions, diabetics, and sometimes other medical conditions. So we need to improve perioperative care stress to improve the perioperative conditions. Surgery within 48 hours reduces mortality, and undue delay usually adversely affects the outcome. Orthogeriatric co-management, but as I told you that is not available in many centers. Optimized fluid balance, anemia, anticoagulation, reversal, etc. This anticoagulation reversal is very important, but it usually takes times. So, as in many of these cases, we prefer spinal anesthesia, but in these conditions, sometimes if anticoagulation is not reversed properly, so we have to rely on the general anesthesia, which has got its own complications and problems. Nerve blocks and for pain control, these can help if available. Pressure injury prophylaxis, DVT prophylaxis. DVT prophylaxis is definitely very important, and it has been seen that it is not very properly considered in our settings, and it does badly affect the outcome. Baseline cognitive and functional assessment for the post-operative recovery, particularly. As far as anesthesia is concerned, as I told you earlier, that spinal anesthesia is preferred, and general anesthesia usually when if spinal is contraindicated. And it is a common practice that we usually ask for prolonged fastings, and we avoid the fluids. So usually this can also badly affect the outcome. Intraoperative normothermia and normotension, and this tranexamic acid to reduce blood loss. This is hardly considered in our settings. That is very important. And rather, in many centers and many doctors and anesthetists, they probably think otherwise, that it may be because as we also go for this anticoagulants therapy and we try to use this, Clexane. So these are opposite to each other. So many anesthetists and the doctors who are caring them, they are confused. So post-operative care is also very important because the immediate post-operative, care, we'll try to make the patient sit early in the bed and try to take care of the chest physiotherapy, allow the patient to breathe deeply and cough, and also monitor this oxygen saturation. Similarly, if the patient is of the fracture was stable enough, we try to mobilize the patient, and similarly, the pain control is also important. Thromboprophylaxis should be continued in the early postoperative period, and many patients, almost half of them, uh, particularly of the later decades, they are usually delirious. So we need to assess them properly and try to find out the cause. Most of the time, it is the oxygen saturation which is decreasing, probably due to the chest conditions or otherwise, or if opioids are used too much. And sometimes it is the electrolytes imbalance that is causing or even worsening this delirious conditions. Complications. Yeah, this is a very, I mean, uh, bleak condition. Mortality is very high. As I told you initially, that initially we used to talk about early mortality within 30 days mortality. Even that is very high. Usually nowadays, many, papers, they usually tell about up to 10 to 20%, but we usually talk about 30% mortality. And most of these elderly patients of later decades, they usually perish in about 30% of these patients, they cannot survive. And the 1 year mortality is also very high, ranging between 25 to 30%. Delirium, 30 to 50% post-op, associated with dementia and poor outcome. Pneumonia, the second most common cause of post-operative death. DVT, pulmonary embolism, without prophylaxis, DVT in 40 to 60% of the patients. You see, it's a very high, I mean, ratio. So that's why in all these patients, prophylaxis should be definitely instituted. Pressure ulcers, immobility, poor nutrition, incontinence, and anemia, particularly, that adds to the pressure sores. And if they are also very, terrible and resistant to healing once they occur. The best thing is that let not these fractures, these ulcers to occur. UTI, catheterization and dehydration and mobility, again, it badly affects the outcome. Surgical complications are mechanical. As I told you, that femoral neck fractures, the most important is the AVN of the femoral head. So it from 10 to 35% of these patients, even after the proper fixation, they go into avascular necrosis. Non-union, usually the cervical fractures, they have 5 to 10% overall, and this figure also rises in many folds if the delay is done in the surgery, and if the fixation and reduction was not very proper. Implant failure, as these are osteoporotic bones, weaker bones, and if the proper, basics are not considered properly in treating these, fractures, so implant failure occur. Many a time the cutout of the lag screws, implant breakage, and further communication. Periprosthetic fractures, usually more common in orthoplasties. It is the femoral, component, which usually it is the femur fracture occurs usually around these femoral implants. Dislocation of the hemiarthroplasty and total hip arthroplasty. it is said that it's more common in the total hip arthroplasty. Previously, many people, they used to go to the posterior approach for this arthroplasties. And in that approach involves the cutting of the short muscles of the abductors and all that type. And that usually, increase the risk of dislocation. But nowadays, most of the time, it is the lateral approach or the anterior approach which is used, and most of the muscles are saved. So less dissection is done. So dislocation is not that common in these operations. Leg length discrepancy, malreduction or shortening from collapse can occur, definitely. Or infection, superficial infection, deep infection, osteomyelitis, septic arthritis, all these are the possible complications, and different patient conditions and the operating conditions and the post-operative care all, collectively add to these complications. Outcomes and mortality. As I told you that the 30-day mortality, they are talking about 10%, but we have seen practically it is much more than this. 1 year mortality, most of these studies shows that 25 to 30% of the. And the great concern is that 50% of these patients, even after the proper treatment, they never return to prior mobility. And many factors, add to this much figure. And particularly, but the most important is the lack of post-operative physiotherapy. And less than 50% of the patients, they return to their original, mobility level. Prognostic risk factors, age group higher than 80, and dementia and the female sex, and all these are the increasing risk. Pre-fracture mobility stage and good ortho care and post-operative, physiotherapy, that helps to early recovery and decreasing the risk of the time. Surgery timing is very important in all these conditions. In the neck of the femur fractures, delay not only causes other problems, but also increases the risk of AVN, and delays in this trochanteric and pertrochanteric fractures, it delays the outcomes, and usually mortality is increased with increasing delay. Rehabilitation and functional recovery. Usually protocol is that on the very next day, we make the patient sit in the bed and we ask for the normal limbs to be mobilized properly, and the foot, toes, all these should be mobilized, and the chest physiotherapy should be started. Patient should start deep breathing. And if the fracture is well, stable one and fixed nicely, so foot weight bearing can be started. And particularly in patients who are, in which arthroplasty is done, they can also be mobilized early, particularly total hip arthroplasties. In phase 2, 1 to 6 weeks, again, physiotherapy and occupational therapy sessions should be done, walking aids with the frame and crutches, so that they should gain further strength gradually. Stairs training should be done before discharge, and occupational therapy for home assessment should be done. This is 1 to 6 weeks. In 6 to 12 weeks, further strength and balance exercises should be instituted. A precaution should be told that these patients should not sit down, on the Indian desk, like the Indian commodes, and they should be told about all the programs for prevention of further falls. Because many a times we have seen the patients to develop a fracture after a year or so in the in the other side, in the other hip also. So the living conditions of the patient should be improved to the maximum. Either her eyesight should be properly checked, and all the facilities should be provided for the comorbidities to properly treated. Prevention and secondary prevention prepare. Well, as I told you that it is a fragility fracture and osteoporosis is usually present in almost 80% of these patients. So the bone health should be, properly addressed. And one simple thing is that patients should have adequate calcium intake, vitamin D intake, and a proper exercise, weight-bearing exercises and resistance training to maintain bone mineral density. Because it's just not the taking of these medicines. If the patient is lying in bed, he or she would pass all his or her skeleton in urine. So weight bearing and stress and resistance is very important for muscle growth and bone growth as well. So lifestyle, smoking cessation, alcohol reduction, and protein-rich diet is very important. Medication review, reduce fall risks, taper sedatives, and review antihypertensives, and try to take the balance. Very important that the patient should be able to be balance herself properly. Annual eye checkups and balance training should be properly instituted.
जी 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 इस्लाम
So, bus we're trying to just, it's probably the last one, I think.
ओके
These are certain special conditions in adults, young pediatric patients, and pathological fractures. The only thing is that the metastasis, as the patient, usually these are in the later decades of life. So many of these patients, they have malignancies, and this femur, head of the femur, and the subtrochanteric region is a very common site of metastasis as well. So if the patient is already diagnosed, so that's, fine. We can straight away fix the fracture site, or otherwise we can take the biopsy and then the fixation of a. Rather, it is said that if even there is no fracture and we have found that there is a metastasis in a bone, so that should be, promptly fixed before the fracture occurs even. Now, here I will talk about a little bit that along with the calcium and the vitamin D, we usually there are other things which are commonly used in medication, particularly the biphosphonate salts. These are very important in a way that they reduce the they the bone resorption. They provide they try to stop the bone resorption. But taking them for years, more than they said that for more than 5 years, then they make the bone more brittle and they become more prone to fractures. So they should be utilized for 2 to 3 years, and then it should be stopped for a year or so, and then they can be reinstituted. Similarly, in the hormone replacement therapy, it has got its own side effects as well, but that can also improve the bone quality of bone. One salt, which is this is the strontium granulate. It is available in sachets, but it is not approved by FDA and European drug agencies. Still, it is available in Pakistan and many other third world countries. But it is said that although it has good, results, it increases, it not only improves the catabolic effect, it tries to prevent the catabolic, but it improves the anabolic effect also. Osteoblasts are also stimulated. But the risk of these thromboembolic embolism and these risks are increased by their usage. So they should be, very carefully utilized. Now, the key takeaways: hip fractures are a global health crisis. Incidence is rising, and 1 year mortality reaches 20 to 30%. That's very high. Anatomical location determines blood supply risk, intracapsular fracture risk, AV and extracapsular fractures do not factor this avascularity. Cardiac calcification usually guides treatment for femoral neck fractures. Surgery within 48 hours reduces mortality. That is very important. That the facilities should be provided in all the, important cities, not only the major, but even the smaller cities also. We should have a proper orthopedic surgeon and an orthopedic a setup where there is orthopedic tables and image intensifiers are widely available, and also the proper peri and post-operative care facilities are available. Delay of every 24 hour adds 10% to the 30-day mortality. You see, it cannot be, more than this. Multidisciplinary ortho geriatric co-management reduces complication in hospital stay. Complications are common: delirium, DVT, AVN, implant failure, infection that can be anticipated and properly treated. Secondary fracture prevention via fracture license services and osteoporosis therapy reduces these risks up to 40%. So what we can easily do is that we should try to modify our lifestyle, try to do a little bit of exercise, try to take healthy meals, increase proteins and calcium uptake, and some sun exposure, because sunlight is very widely available in our regions. So maybe it would cause little darkness of the skin, but otherwise the bones would shine up. So these are the things, and on the government level, we should try to have these orthopedic facilities. This is not only just the production of the orthopedic surgeons, because they should also have proper facilities, and so as to gain proper experience to treat these fractures. Because these fractures, if treated by not very well experienced surgeons, then the results would not be very good. So thank you very much. Any questions, please?
Ji, Professor Qasim, thank you so much. Very nice presentation, and especially very, very important this topic. I myself experienced that there was a fracture of my father when he was an 87, 88-year age. And
Yeah.
the same, my maid working in my house, she is a uh, patient of asthma, and she was taking the drugs of the asthma, which reduces the density of
Steroids
the
probably she will be taking.
yes, density of the bone, and more prone to fracture of this. I myself experience how it is very difficult. I will ask other people how to ask. My question is that very simple question, very such simple question.
Yes, please.
My simple question is how you will advise in a very simple word, especially such fractures are very, very important in the female after menopause, and very common, like I gave the example of the people over the 70. What
Yes.
is a very simple advice of you from your side, so that we
Yes.
can save our pelvics and this other neck of the
Yeah.
female? Ji.
Well, this is a very important question, that we can prevent these fractures with two simple measures. First is that we should improve the quality of our bones and muscles. And secondly, that as it occurs in elderly patients, so their surroundings should be very clear. If they have a room, they're living alone, so it should be well lit. And there should be clear way to the bathrooms, because there's a very common history. You will see that these patients, they get up late in the night trying to go to the the washroom, and then they fall somewhere. So
Very good, sir. Another my advice
yeah,
as a senior person, as a old person, is that whenever you are after 70, you have chappal pehente hain na, that should
yeah,
be
बिल्कुल
in
जी जी
such a way that should not be slippery, and because that is
yeah,
causes the slipping. And as nowadays in every house you are looking the tiles which are very slippery. In our days
yeah,
there were bricks, but nowadays there are very, so I
yeah,
will advise the
they are
people
tiles.
who are of my age that they should
Yes.
care of their not only their muscles, bones,
Mhm.
and small walk daily, but also their activity like infrastructure, like their chappal, like their wares, and whenever there's. So thank you so much. Dr. Salma Kundi has raised the hand.
Yeah, please.
Ji, madam.
Ji, Assalamu alaikum. It
Mhm.
was a lovely talk by Dr. Qasim. What concerns me is Angelica is here and Dr. Shella is here, and they'll talk about the well-being at some later dates, women well-being, female well-being. But I think the most important aspect to even men's well-being besides female is having healthy, shiny bones, the term coined by Dr. Qasim. We can have dark skins, but let our bones be shiny. What a nice thing to say. So the basic crux that I've taken from today's lecture is have ample calcium intake. What about bisphonates? Do you recommend it to everyone? Like in our type of a country where we are all, most of the population is undernourished, do you suggest we should take it?
Yes,
Dr.
Well, I
Qasim?
think that
Salma, very good question, and the same similar question that was coming in my mind was same as you have asked. Thank you, Professor Salma. Ji, Dr. Qasim,
ji, ji.
Dr. Qasim, we are not looking your face. Can you change your camera? That camera should index on your face. Okay, okay, a
I
little
don't
bit
think that
raise your face. Yes,
now my
yes.
voice has gone
Thank you so much.
somewhere.
Thank you so much.
Anyhow, if you are listening me,
Yes,
so
very well.
yeah. Well, the problem is that the calcium and vitamin D can work very well if the patient has not already, I mean, suffered from this osteoporosis. But if osteoporosis is diagnosed, I think then bisphosphonates are very important to add, I think, and it would help because osteoporosis it becomes at times it's symptomatic that I've seen many patients they come with the backaches and other pains and aches, generalized aches. So their quality of, I mean, extras even then can tell. Although they said that 30% of the skeleton should be, I mean, lost before it is available. I mean, it is clear on the X-rays. The best thing is that the DEXA scans that can very easily tell that whether the bone is osteoporotic or not. And in that condition, I mean, this adding biphosphonate salt is a good thing because it increases it tries to stop the, I mean, osteoclast. So the quality of bone deposition is increased. But again, because it is the balance between the osteoblastic and osteoclastic activity which gives us a healthy bones. So even if the one of the processes, I mean, this osteoclastic activity start for many years, the bone would keep on adding and the bone would becomes brittle. And then sometimes they can add to another fractures, the brittle bone fractures we call them. So usually it is said that these salts can be taken for, usually in the literature they say that we can take it for 5 years. But I think for a year, 2 or 3 are good enough. And then we can stop them and we can keep on, I mean, using these calciums and vitamin Ds.
Yes.
And this would help. And particularly during that years, you should try to be more exercise prone and also the diet should be, I mean, good enough. More adding more proteins to our diet.
Okay,
So,
great. Thank you. There's
Ji,
another question. Many
yeah.
people say that when you fall, you have a fracture. But
Hmm.
there's a layman term over here in our area, and they say it's actually a silent fracture which causes you to fall. So, what is
Hmm.
true? Is it true?
Yeah. Well,
Yes,
initially
demonstrate area
we
silent
had,
fracture.
I mean, we tried to, because the osteoporosis was so much that it was said that the fracture occurs first and then the patient falls. So in certain many cases, it can happen. And as I told you, the case just few weeks ago, a patient, he presented with groin pain and there was no clear history of fall. So the fracture occurred, I mean, accurately due to continuous strains. Because even it is said that when we try to get up from the bed, so a lot of force, even double our weight, body weight, occurs at the hip joint. So if the bone is already weaker, it can cause fractures. But these impacted fractures, sometimes patients can be ambulatory. They can come, they can walk. The type 1 and type 2 fractures, where
Yes.
the fracture is impacted, and but the pain is there. And
Okay,
even
fine.
that is difficult to diagnose with simple X-rays. We usually have to go for MRIs to properly
MRI
diagnose the
and
fractures.
scanner. Thank you, Dr. Salman. No doubt, very good question related to fracture of this today's topic, really. But I think more osteoporosis. Before I go to Dr. Shaila, because when I go in the I am a 70-year-old, but when I go for a walk, I use this stack always because you should be very careful because when you are walking and when you are going to your usually at home your home you are very prone to become slippery and there is danger of this when you fall on this solid area and there is So this is the stick that one thing. Second thing is that what I have seen in my life, no doubt the bone is very important, but the muscles are more than important because the muscles are the protector of these bones. I think Dr. Qasim, Professor Qasim, you will agree with me.
Yeah, yeah.
Dr. Shaila, Dr. Shaila
जी
Bakai, over to you.
जी थैंक यू सो मच फॉर एन एक्सेलेंट टॉक और बहुत जबरदस्त आपने यू गाइडेड अस थ्रू आउट क्रक्स वही है सर कि प्राइमरी प्रिवेंशन इज बेटर देन ट्रीटिंग with later on with bisphosphonates. They can be added to high risk people, but जैसे आपने explain किया reducing fall risk and optimizing bone strength and bone health and also preventing sarcopenia and the fragility fracture risk, the muscle mass and everything. Actually sir जो हम लोग जो देखते हैं वो I see many patients around 45 55 in between, they report with bone pains and lot of back pain. And those are the people who really need this osteoporosis screening and risk prediction. And then adding bisphosphonates if required through consultations. They also need a medication review. A lot of polypharmacy हमारे यहाँ हो रही होती है. Lot of people are receiving steroids. So I think we need to have a medication review for them and then pharmacological prevention. और आपको पता है कि ऑर्थोपेडिक सेंटर्स इतने तो है नहीं हमारे पास, ऑर्थोपेडिक सर्जन्स भी नहीं है. So all healthcare professionals need to be sensitized and they should address fragility and sarcopenia, adequate lifestyle modifications, protein intake, and also manage comorbidities accordingly and have a strong index of suspicion for them. Because in women health, musculoskeletal health is very, very important in midlife and beyond. तो सर मेरे तो 2 cents ये थे कि we need to really the preventing strategy is multifactorial. We need to
Of
combine
course, yeah.
bone health, fall prevention and then risk based treatments. तो
Yeah.
एक मेरा आपसे क्वेश्चन भी है सर, what
जी, जी.
about ये जो bisphosphonates में many people who can afford would like to have the annual injection, the zoledric acid. तो
जी, जी.
उसके बारे में जरा थोड़ा सा अगर हो जाए तो अच्छा है सर. How frequently it should be given in women with T scores greater than 2.1 और इसको मतलब annual या biannual करना चाहिए या 2 years पर
Actually,
करना चाहिए.
I mean, their efficacy is almost same. It is just the way how you want to take it that actually determines the cost. I mean, it's very easy to have a yearly injection rather
Yeah.
to have a pill on a daily basis or weekly basis. But I think that I used to usually prescribe a monthly tablet. That is much easier and doesn't cost too much also. And as well as efficacy is concerned, I think that is almost similar. But only thing is the compliance, because if a pill is prescribed on daily basis, many patients will fail to, I mean, comply with this. So these
Yeah.
weekly or, I mean, this monthly and even 3 monthly injections are available, and then yearly, but there are patients who can afford them. It's very good to have them.
Dr.
many
Qasim,
I saw some
won't
patients
the oral
having 3
formulation
monthly
for
injections.
gastritis?
I will request, I will go towards the Professor Angelique. Professor Salma, we are hoping and that inshallah very soon next year you will arrange another beautiful conference in Ahmedabad and people like
Inshallah.
legend like Dr. Angelique, they all will be there. And Professor Angelique, thank you so much. Very late night you are with us. Can you add something?
Yes, I hope I'm clear. I just want to say these talks are very important. And, if you look at hip fractures, it's actually such a common thing. And no one really give a lot of attention to that. It's more important if you've got a heart attack or some other disease than just to try to help these patients with hip fractures. But it is a devastating blow to the patient and the family to have a patient with hip fractures. And as you correctly said, or it was stated by the speaker, that it's actually preventable. We need to start doing more bone density for your high-risk patients as well as from the age of 65 for females, and for men in South Africa, the guidelines are telling us from 75, although I think we should do it earlier for men as well. But all in all, very good topic.
Okay, Angelique, thank you so much.
Thank you so much. Over to you, Professor Salma, to conclude today's session.
Okay. Thank you for all the participants, especially Dr. Shella, Dr. Angelique, Dr. Mazhar is here, and there's so many other regular attendees. Amna Shah is here, Kaisar Sajjad Saab,
सजाद
Rashid
साहब भी
Saab,
बैठे हैं, अगर कहना चाहे मैडम इनसे पूछ लें.
Rafiq Hanani Saab, Zafar Tanveer Saab. Thank you for all being here on the Sunday. And my special thanks to Dr. Qasim. Dr. Qasim, you gave us your Sunday. We are so obliged to you, and you gave us
welcome,
a takeaway message. And I'm going to take a Zolendro very soon next week, inshallah. Inshallah. Now, the thing is, Dr. Kaisar Sajjad, would you like to make a vote of thanks, being the PMA stalwart? Dr. Kaisar Sajjad?
Thank you very much, Madam. Actually, I have joined late, and for that I'm sorry. I always
लेट कर देता हूं मैं.
जी हाँ, बिल्कुल. I
किसी को
always
फोन
say
करना
that
हो, किसी के पास जाना हो, हमेशा लेट कर देता हूं मैं.
तो कोशिश करूंगा नेक्स्ट टाइम ना हो, इस दफा माफ कर दें. So I always appreciate Mulazim Sahab and Dr. Salma Kundi. They are doing wonderful job. And on behalf of the Pakistan Medical Association, I appreciate both of you and all the team members who joined in a very busy Sunday, which is very difficult for everybody to spare for these this type of activity, I think. And my special thank to Qasim Saab, who has presented an excellent and fantastic presentation on the topic. I hope that a lot of information has received by all the participants, and हमारी तालीम में बालगान में इजाफा हुआ होगा बहुत ज़्यादा. तो well done, Qasim Saab. I appreciate for sparing for time for this webinar. Thank you very much, everybody. And thank you very much, Mulazim Saab and Dr. Salma Kundi Saiba, for giving me this opportunity to thank the audience. Thank you.
Thank you so much. Thank you so much.
Dr. Qasim Saab, special thanks to you. We are all grateful to you. And Allah bless you all. Have a very happy weekend. Pakistan Zindabad.
Zindabad.
Thank you.
कैसा सजाद साहब, वो बालगान जो होते हैं वो 18 साल तक होते हैं. यहाँ पर मैं 70 को क्रॉस. तालीमे बुजुर्गान.
हाँ, बुजुर्गान. तालीमे बुजुर्गान, आप सही कह रहे हैं, बिल्कुल. हाँ.
ओके, हमेशा हंसते मुस्कुराते रहे. पाकिस्तान जिंदाबाद.
जिंदाबाद. आप लोग खुश रहें. Thank you.
Thank you, Umair.
God bless you, everybody. Thank you.